It's about 11 o'clock on my clock, so let's get
Home
started.
Tony from Mumbai, India.
Oh, hello.
Hi, how are you?
Good, how are you?
Good
Great.
to good to good to see you. Good to waiting to listen to you.
Well, welcome to everybody. So again, this is our CMR Journal Club. I'm Nicole Cyberlick from the University of Michigan, and I am hosting this week. And I think we have a really great topic this week. We're talking about reference values, which, this is like one of my favorite things to look at because I think having these huge groups of data sets and understanding, what normal looks like is really essential so that we can understand what abnormal looks like. And so I'm really, really fascinated when we have huge amounts of data and we actually get to understand exactly what we're looking at. So we have two great speakers today, and we'll get started in a second. I also want to say thank you so much for joining in one of the busiest weeks of the year, the week before the ISMRM, for those of you who celebrate that week. So thank you again for joining. Okay, so our first speaker is Dr. Liliana Szabo, and she'll be presenting the paper which is entitled Cardiovascular Magnetic Resonance Reference Ranges from the Healthy Hearts Consortium. So I'm going to hand over the baton to Dr. Szabo, and you can tell us about your paper.
Thank you very much. I hope everybody can see my screen now.
Yeah.
And thank you very much for the invitation. It's a great pleasure to present our results on behalf of the Healthy Hearts Consortium. And
I'm sorry to interrupt. Could you make your PDF for your full screen just so we could see it a little bit better?
Of course.
Perfect.
Yeah,
Okay.
Let me know if
that's perfect. That's great.
Okay. Yeah. Just before I start my presentation, so this is part of a greater body of work, and this is one of the first paper basically that we produced as part of the Healthy Hearts Consortium. And basically the premise or the main reason why we started off this huge body of work is basically that of course understanding the normal values and normality or just the reference ranges in itself has clinical implications. And of course, when we looked at the literature, what we found as a previous work to the Healthy Hearts Consortium's establishment, that there is a large variation between the published healthy reference ranges, which could be attributed to population or technical factors. And obviously, there are many methods to try and work around this fact. And obviously, the next presentation will be presenting one of the largest work in this area. But what we found is basically collating these already published reference ranges. The raw image could allow us to reanalyze these healthy hearts with a standardized method, and this could potentially work around any additional issue, and this could basically allow us to, with the same type of analysis method, look at what health means. So the Healthy Hearts Consortium is an international collaborative which collated the healthy adult scans from all over the world, and it includes more than 8,000 studies, which was contributed by 6 major sites. And this is just our central illustration, which shows all the sites. And in this first work, we worked with the CVI42 software, and we used automated batch processing, and I will get to that a bit more detail. So basically, all of the images were collated from all of the sites with a preset of covariates, which includes sex, ethnicity, body size, so height, weight, and we collated the dye conformated images, and we worked on a standardized processing pipeline where we run the batch processing on a local computer, and then once they were ready for scientific analysis, we used an in-house developed quality control application where we basically manually went through the cases and looked at their quality, not just in terms of the segmentation quality, but of course we also scored the and I will just scroll down a little bit. So we basically worked on a segmentation, a quality control pipeline, which allowed us to score these images as perfect, satisfactory, or unacceptable for our clinical use. Yes, and I will go back just a little bit because obviously the UK Biobank dataset always raises question, and for the purposes of the Healthy Hearts Consortium, we reconfigured this dataset, so not all of the UK Biobank participants were used in this analysis. And what we did is basically to address the super healthy bias, which is obviously present in most huge data sources. We recalibrated the demographic, socioeconomic, lifestyle, and morbidity profile of these participants to best reflect the general population health based on the Health Survey of England. So this is how we received that healthy cohort, and obviously all other contributing sites also went through a similar pre-screening for healthy participants. And the segmentation modalities that we used were included all of the Society of Cardiovascular Magnetic Resonance endorsed segmentation methods. So what we did, we basically named these smooth, papillary, and anatomical. And the smooth meant, of course, that the papillary muscles and the trabecular tissue were excluded from the myocardial mass. And the papillary was where we used the smooth endocardial contour with the inclusion of papillary muscles within the myocardial mass. And finally, the anatomical, which is also quite widely used, is we included both the papillary muscles and the trabeculi in the left ventricular mass. And just to get this figure basically just shows what we found. And we also wanted to make sure that we include both all used body size adjustments, so both height and body surface area assessed or adjusted values were also presented. And just to briefly go through, we of course age categorized the population and we stratified our reference ranges by sex, age, and ethnicity. And what we present in this paper is of course, the prediction intervals, which present the range where a given value is likely to fall in a single new observation. And we also provided as the supplementary material of this work the median and the interquartile range for this population. And what I also wanted to highlight before we go into we also looked at any of the technical factors. And obviously, we have to mention that most of the scans were from 1.5 T scanners, and quite the majority of the values were derived from a Siemens scanner as well. So these are technical kind of limitations that we definitely have to mention. Yes, and within the main manuscript, we present a small subset of reference values for most clinically used values, ethnicity and age and sex stratified. But within the supplementary material, all of the readers can find a very detailed outline of all of the segmentation tools and everything that they could potentially be interested in. And let me just jump straight to our website, where the readers can obviously find all information. They can find the reference ranges that they are interested in, because we know that it can be quite tedious to just go through pages and pages of tables. So they can readily search for those tables that are the most relevant for their question. And we also actively update this website. So within the resource library, they can see our newest extension of the work, which can be for now can be found on medRxiv. But obviously, we are very interested in any kind of feedback from the wider audience, so that we can present the best values that can be most clinically used. Thank you very much for your attention.
Awesome. Thank you so much for bringing us through this very complicated study. But
Yeah, I'm so
really,
sorry.
really important. No. Complicated in a way that makes me very impressed with how you've managed to put it together. So if anyone has any questions, you can go ahead and drop them in the chat, or unmute yourself and ask your question. But maybe I can start with a question. So maybe I didn't understand this correctly, but you manually went through all of the images to give them a rating of perfect, satisfactory, or unacceptable? Is that correct?
So for all of those cases that were not from the UK Biobank, we went through manually and scored everything. But so this was the first study. But because what we found is that even in studies like the UK Biobank, so in this first edition, what we used for the quality control for the UK Biobank was just a statistical an outlier detection, but with our updated value, just because the consortium already commented on those things and the importance of quality control, especially when we use any kind of automated tool. So for the next edition, we went through all of the images and
Wow, okay.
I looked at all of them.
And have you published the results of the ratings? Because it would be interesting to see, even, in healthy subjects who I'm assuming are easier to scan than, patients, what fraction of studies were unacceptable? Even, again, in the best case scenarios. Have you published that, or is this something that you have handy?
Yes, so within the supplementary material, the readers can find all of these numbers, and we agree so much so with this notion of having to QC these images as much as possible and be very transparent about the number of cases that are, for example, in terms of the right atrial values, and obviously any kind of atrial values, we had more to exclude. So just in case, so for transparency's sake, we for the next edition of the work, we detailed an even more detailed table where we exactly report what number of cases were removed for which reason. So were they removed because of the visual quality control, were they removed because due to the outlier or nonsense values, because we found that these are very interesting, especially in the context of a multi-center study. Yes, and is it okay if I just share the QR code for the other work as
Yes,
well,
of
so
course.
that anybody who is interested can, they don't have to.
Go ahead, Matthias.
Yeah, thank you very much for presenting that. And I was also involved in that, so the amount of work was and to get that off the ground, it was humongous. So special thanks to Liliana and Stefan, especially for keeping on track here. So there is one opportunity here to go after the question that we have discussed since I think 15 years. Which method is the best to include papillary muscles, exclude them? And it's probably no surprise to some here that I've always been a proponent of the anatomically correct, although I'm perfectly aware of the limitations. My question is, did the paper and the work on that allow you to get a feeling of which method you would prefer? They are certainly the simplified contours. They have been initially the favorite because it was just what the software could do in terms of the ease of use and ease of application, then, and also reproducibility. But of course, when it comes to accuracy and diagnostic value, especially in hypertrophic cardiomyopathy, there have been concerns about that, and we have published even a paper from Heidelberg about that. And then when you compare it with other modalities, then there's only CT, and CT, of course, does not use simplified contours, and also the consistency with flow data. So when you do volumetric stroke volume with flow generated volumes. So I wonder whether you have, when working with that, whether you developed a certain preference for any of these methods, and feel free to say whatever you want. So I just try to explain my stance here.
Yeah, thank you very much for the question, because I found this is extremely exciting, and because obviously, especially when we did the manual contours in predating this work and predating the AI boom in segmentation work, which is basically explainability in its best, because we can already look at all of those images. So I think especially with these segmentation tools becoming stronger and stronger, a preference and a growing preference toward anatomical contours will probably, or my sense is that it will be definitely growing, just because of how accurately we now can measure them, and just the importance of this topic. What we are now aiming to do, or there is a proposal and an ongoing body of work, is to try and look at the clinical impact of these different kind of reference ranges and how they could potentially change clinical decision. And I think especially so these implementation type work, or this kind of work will definitely change how we look at reference ranges in the future.
Thank you.
Thank you so much again,
Yeah.
Dr. Szabo. So I'm sure we have a million questions, but in the interest of time, we're going to move to our next speaker. I'm very excited to introduce Dr. David Bluemke, and he's going to be presenting his paper, which is entitled Reference Ranges or Normal Values for Cardiovascular Magnetic Resonance in Adults and Children, the 2025 update. Perfect. All right, so you can take it away.
Okay, thanks very much for the invitation to present this. I'm really presenting it on the behalf of many authors, of course, and especially Dr. Boom, who was spent about 2.5 years on this one paper. Fortunately, you know, I'm not going to present the whole paper. It's 74 pages on a PDF, and it's 244 pages in the Word document. So there's a lot of information, but I think I'll talk about a little bit about the methods that were used, and then we'll be able to see, hopefully from there, you know, how it could be used. This is the third paper in the series. The series started in 2015. And every 5 years, it seems to us and others that there have been enough information in that interim. And things change and so forth, the databases expand. So pretty much for these basic parameters, the LV mass and function, right ventricle, those are the groups that have really changed in terms of UK Biobank, other large studies around the world. But the pediatric population and publications have changed quite a bit. Also, as these populations expand, some people are interested in maybe age or ethnicity-based data. And so that's becoming a little bit more possible as well. For the statistical analysis and the selection of papers, you know, it's always possible that something gets left out, but there has been a lot of effort to select kind of highly, let's say, the most valid studies based on a couple of criteria. There are still studies that are published in some of these specialized areas that have less than 40 subjects, or it might be 40 subjects with only, you know, only males and no women in the study. So those become rather difficult when the sample sizes become low. And then identifying the healthy reference cohorts in our papers. If we're doing clinically based papers and these are people referred for MRI, you know, they're not necessarily the healthy reference cohorts that we were intending to use. So those mostly were excluded unless, you know, there was really good certainty published in the study. And then, of course, some of the methods are not really used, have not been based on SCMR guidelines in some of the papers. And when possible, if there was an SCMR guideline, those manuscripts were excluded in that case, but still leaving plenty of data for everyone. I am looking at the proofs. The full paper is not out yet. Hopefully in the final paper, there'll be bookmarks, as you see on the right-hand side here, but we'll have to deal with the publisher on that. So for each section, there is typically an image that's included that would be representative for that particular database or the dominant database, showing the reader how that was done and how the measurements were taken. And then after that, there's a main table that summarizes the most important, we think, relevant parameters to the software that was used, to some of the definitions, manual contouring, automated contouring, and so forth. This table also shows the distribution of men and women and the age range. And so at some sites, I think it's feasible or possible if there's a publication that's very relevant to your center, rather than using the aggregate data, it would also be possible to go back to these original publications and you know, see how the data was used originally. As far as the largest studies, this is the table for the RV and LV mass data. We see now publications from China, from Hungary, other areas that were not previously represented, and the large health study from Canada, and the paper that we just heard about in the Healthy Hearts Consortium, and a description of succinct details for those papers. So that's kind of the methods. I'm going to go over one of the data tables just as an example. I think there are over 80 data tables, so we're not going to do many of them. But for each data table, at the top, it's the description of the parameters and a little bit about the breakdown. Is this age-based or gender-based? And then some of the key methodologic conclusions. So if your site includes the papillary muscles and the LV mass, here are the references that were used to derive those data. And finally, the upper and lower limit for the data. And the next table, for example, the papillary muscles and trabeculations were included in the volume. And then again, the references that are available, in that case, just slightly smaller. the data that's there. So that's kind of the general kind of organization and how to use this. And for LV mass, then one of the populations that got a little bit expanded now, let me see if I can go to the right table, page 33. So if you have athletes, this is a reference table for athletes, you can see that the number of data points is usually substantially less, 143 men and women, 101, 42 men only in this third reference study. There's really not that much when these particular methods are used. And you'll see here's a summary data table in reference to kind of a specialty area for athlete data. This particular table 42 has 100 men and 49 women. And the other table, we can see where, for example, left ventricular volumes, 261 is very large volume for these elite athletes. So if you have these situations and you're not sure about athletic status, at least you can go back and look at some of the papers that did go over those topics. So the next little bit, I'd like to talk about sort of opportunities and what is missing in a sense. So I'll try to go to this table. This is the table for flow values, and kind of illustrates the magnetic field strength that was used and the technique 4D flow, a 2D flow paper, and another 4D flow paper. So there's not so many papers here that met the cut. And then this next table, staging of valvular heart disease. There's really nothing in the MR literature. We've been using the echo parameters for staging progressive or severe disease, and might represent an opportunity, for example, from the future. So we have our MR paper using those parameters, basically from another modality. So that's kind of interesting that that's still the case. Just another area that kind of gains in popularity over time are distensibility and pulse wave velocities. You can see the relatively small numbers of papers and participants here that were used to derive some of that data. So, with the advent of 4D flow in particular and more quantitative analysis of vascular studies, that I think is somewhat relevant as well. And then if you're an individual site that are working on perfusion analysis, those studies of normal data really becomes limited. And part of that, I'll show you that here. Here's some of the, here's the section on myocardial perfusion in adults, methods that were used in some of the key studies. And then we come down to relatively small, let's say you're using regadenoson. The normal study, I think, was from 2013 for 15 subjects for regadenoson. So these represent kind of opportunities in the future where maybe we need to build up a little bit better data for these studies. And I guess one of the topics that came up for a little while also in this regard was triglyceride data is now in the paper. Let's see if I can get that. One of the last papers. Last tables. There has been some study and interest over triglyceride content from spectroscopy, and all of those have relatively small numbers. All of them are unique because of the techniques that are done, something, for people doing spectroscopy, things like that. So I'm going to stop there as far as, the stuff that's in there. I think one of the things that Matthias was getting to is the evolution of the software packages, which for analysis, but also the evolution of the MRI pulse sequences. So we changed from a General Electric, a conventional sequence, to what they refer to as sonic DL. We have deep learning on every sequence at this point. And the normal values have changed. We can see the contouring using the same software package has changed. So I think one of the ongoing needs we will kind of require in the future are the automated analyses that Liliana explained as well. This is a really big factor. We'll have to do probably version tracking, both of the software package as well as the pulse sequence as it goes on, as the vendors add AI to their sequences. So I guess there'll always be work to be done in this area. So I think I'll stop there and see if there's any questions or comments.
Thank you so much for that, again, amazing body of work. It's a huge amount of data to be going through. Okay, Matthias, go ahead.
Yeah, so yeah, I want to echo what Nicole just said, this monumental effort here. So David, this is really kudos goes to you and the people you worked with so hard. So another pet peeve of mine has been also next to the method of including the trabecular, so anatomically correct structures, was the indexing. And I was just wondering about your opinion on that. So the tradition has been that we indexed to body surface area, and the values are all indexed to that. Mostly, so they're reported here in the paper. But genetically, the body surface area is not determined. It's the lifestyle that produces overweight people, whereas the height is. So a severely obese patient will come up with pseudo-normal values for LV mass, but we all know that this is hypertrophy with all the consequences with respect to prognosis. So I was wondering why we cannot always by default also report, at least also report the index values to height, which would better reflect the pathology in certain cases.
Yeah, so that's a question that I've been thinking about for, I guess, 25 years as far as we've been doing the MESA data. And the epidemiologists have been concerned. They pointed out that our indexing method is derived from data in, I think it's 1908, if I remember the year correctly. And, it's kind of very odd system that we use. So in short, I think that the reason that it's reported that way in this particular paper is predominantly related to the ECHO guidance. Their values, I think, are relevant, and their methods are relevant to what we do in MR for better or worse, and maybe we can do better in the future. When we have studied outcomes in MESA, there are several papers that kind of are buried in obscure literature because the reviewers in our field and others were not all that excited. But the outcome differences were not that large, I would say. And looking at a variety and the epi people's optimum body size adjustment is just to add height and weight into the multivariable equation, let the coefficients be determined by the physiology. Then you get very weird coefficients that we've never used. There was another meta-analysis that wanted to use height to the 1.7, echo 1.1 height squared, and so forth. But in the end, I'm pretty convinced there are differences, but they're not so large that we're able to demonstrate so far. So if we have, as you indicated, maybe an obese population and certain select individuals, then I believe that it's possible that there could be greater differences. But there's one more point beyond that, is we report, and our reports probably 15 normal values on every patient. ECHO probably has 25. There are not so many of those parameters that are chosen or been shown to be that clinically relevant to begin with. And the one that's most clinically relevant that I know of is left ventricular mass, and we don't really use that one a great deal in our reporting system. So I think we've got a ways to work on your points that you mentioned, maybe refine the data, and then if we need to, establish a CMR specific guideline.
Yeah. That's what I think. I was thinking the time may come, or it's already here, that we say, okay, we know that our tradition was rooted in maybe in ECHO regarding quantification, but we all know that quantification by ECHO is limited, and we're much better with MR. So I think it may be time to rethink that and move away from some of the tradition. But I also get your point that the prognostic value may not be hugely different, but I don't know whether we have enough data in all the different populations, as you also mentioned, that it may be relevant for some. Thank you. And if I may, the other quick question was, where do you think is the future to with all our networks that we have and large data sets, could there be a time where we all upload normal value or normal people, perfectly normal people and their values somewhere, and this kind of automatically updates so that we have a globalized database, or is that asking for too much?
Yeah, that'd be much easier, much better. The challenge I would say that that we had was the definition of normal, because it's really difficult in the United States to get normal individuals into the scanner. And to do something like perfusion normals is very, very challenging. To do CT normals is even worse, of course, because of radiation. So I think the peer-reviewed publication, the people who review these, when it's called normal, I think understand that we would really like healthy volunteers rather than normal by MRI standards. So I think that's the main challenge that I saw.
Okay, thank you.
Yeah.
All right. If there are no further questions, then I think we will wrap it up for this week. I'm going to hand off to Matthias to talk about our next month's Journal Club.
Yeah, thank you very much. Just very briefly, so on June 4th, we will offer another edition of the Journal Club, and this time it will be about low field. And I'm very happy that Lon Simonetti, who has been leading a lot of these efforts, will be there to present two of their papers on that. So we will have an interesting view on the clinical value and challenges and opportunities with low field CMR. So I hope you can join, and we'll see you, and I will see you then.
Awesome.
Bye.
All right, we'll wrap up, and I hope to see a lot of you in Honolulu next week. And if not, I'll see you next month. Bye, guys.